world, as the urban population in the region is expected to quadruple from 295 million to over 1 billion. And with the emergence of COVID-19, we're starting to see now the impact of dramatic and massive suburbanization and urbanization on health and disease in these regions. So, for example, a report in The Guardian identified that about 250 million people in Africa will be infected with the coronavirus, but that about 22% of these infections will occur in the next year, with about 190,000 people dying in the next 12 months. And this will, of course, overwhelm the available medical capacity in much of Africa, as it has done in Europe and North America and other parts of the world. So there's also a high degree of population movement on the continent, which is about 7 times higher than anywhere else in the world. So this migration is driven by a myriad of social and political and economic factors that force people to travel daily in search of food or work, or visiting extended family members in different countries or in different parts of the same region, or for cultural reasons as well. There's also been the effects of civil war that have affected people and largely pushed them into urban areas for resettlement. And a lot of these rural to urban migrants tend to settle in often informal places along the metropolitan edge. And many rural to urban migrants tend to be poorer than the permanent population in urban areas, live in lower quality housing with inadequate sanitation, and have limited access to health services. So infectious diseases are thus less of a natural disaster, but emerge alongside social and spatial inequalities in housing and healthcare or financial resources. Okay. So numerous researchers have noted that population density, which is of course highest in cities, strongly influences the likelihood of a disease outbreak. And researchers have noted that the dense urban areas and slums in parts of Africa, including Monrovia, Freetown, and Sierra Leone, have been prime sites where Ebola had thrived. And while suburban areas are popularly understood as low density areas, these processes of extended urbanization that we're talking about in developing regions often consists of densely populated new towns of high-rise flats or peri-urban informal settlements with very high densities. But as I'll discuss shortly, it's often the lack of physical infrastructure combined with political and economic factors that result in high density in these places that provide the perfect scenarios for the spread of microbes. So it's not necessarily about density itself. Even though urban density has been widely accused in popular media for the severity of the current COVID pandemic in places like New York City, actually we've seen that Asian cities like Hong Kong, Seoul, and Taipei are far denser, but have had far fewer cases of COVID-19 per capita. So this suggests that overcrowding rather than density is more of a factor here. This is also why we've argued that governance is a more important factor than density in determining the severity of outbreaks, which I'll come back to a bit later on in the presentation. So recent research that we've done indicates that rapidly expanding infrastructure networks and urban landscapes can play a role in the emergence of potential outbreaks, as I've said. So examples include deforestation on the edges of cities and new agro-industrial transformation of hinterlands, producing new pathways of emergent infectious disease transmission. And the fact that the global aviation industry has confounded the ability to contain disease outbreaks has been well established since the SARS crisis of 2003. But it's also relevant here because airports and other nodes of economic logistics and activities are often located in suburban municipalities, which raises very complex governance and jurisdictional issues with regards to who has responsibility to control disease outbreaks in large urban regions. So transportation infrastructure is a primary form, of course, of exurban infrastructure, which can lead to the spread of infectious disease, particularly in outbreak situations. So a recent research paper has found that New York City's subway system was a major, if not the primary, disseminator or transmission vehicle of the COVID-19 infection during the initial takeoff of the epidemic that became evident in the city during March 2020. And the same research notes that bus hubs may have served as secondary transmission routes out to the periphery of the city. So you can see that in the dense parts of Manhattan, you tend to have less incidence of the disease, as well as in parts of Brooklyn as well, which tend to be more wealthy. Whereas in less dense parts of the suburban or outer-lying areas of New York, which are also less wealthy, you have much higher incidences of disease. And you also see the mapping of the subway system through areas with quite high infection rates and the correlation between the drop in new reported cases with also the drop in use of subways in New York. So this corresponds with the findings in our papers about both the potential higher instance of infectious disease in peri-urban areas, as well as the role of transportation infrastructures in influencing the spread of disease. But we also need to look at regional infrastructure networks like transnational manufacturing networks, Chinese finance belt and road infrastructure across Asia and Africa, and in global and regional transportation hubs like Wuhan. So additionally, the lack of infrastructures in rapidly urbanizing regions in the global south can also have severe consequences for the rise of epidemics, as the rapid growth in cities and urban populations is not accompanied by the appropriate development of social and technical infrastructures. And this includes access to clean water supplies, which are, of course, essential for combating the spread of infectious disease, but are also lacking in rapidly growing informal settlements. And people don't necessarily have the ability to self-isolate, as many of us in Europe have been able to do. So rapid growth and population growth and urbanization in Southeast Asia has meant that the number of people using unimproved sanitation and drinking water systems in urban areas has risen by 20 million between 1990 and 2006, and beyond that into the last decade as well. So even in wealthy cities like Singapore, the poorer sectors of the population often have an inability to self-isolate due to dense living conditions and are thus at higher risk of contracting and spreading disease because, as we've learned, these typical containment strategies such as self-isolation and quarantine are not always possible. So as some of you might recall, Singapore was initially praised for its handling of COVID-19 and even managed avoiding and imposing lockdown conditions until mid-April. However, a sharp increase in COVID-19 cases amongst Singapore's migrant workers population then emerged in mid-April, with about 9 dormitories housing more than 50,000 men, which are mostly from Bangladesh, India, and some from China, had been declared as isolation areas and were effectively locked down, meaning that over about 300,000 workers had restrictions on their movements within their own complexes. So this accords with our research, as most worker dormitories are located on the peripheries of Singapore, where they're out of sight of most of the population and tourists and visitors coming into the central parts of Singapore until the issue exploded, of course. So this highlights the inequalities that are emerging from the coronavirus pandemic. And as Singaporean journalist Kristen Han has argued, there's long been 2 Singapores, one for citizens and long-term residents and expatriates, and another one for the low-wage migrant workers who provide most of the labor upon which Singapore's wealth depends. So, as past research has shown, and as we've seen with COVID-19, it is typically these conventional containment strategies that are most successful in containing the disease. But as my colleagues Roger Kyle and Harris Ali have noted, this is based on their view of the view of the bounded city with fixed and territorialized and restricted access, which contrasts with the unbounded character of contemporary urbanization processes and of course globalization. So the emergence of COVID-19 sparked the largest quarantine in human history, as first Wuhan and then many other cities around the world were effectively closed, with most air, rail, and bus transportation halting. So cities like Wuhan and New York and other parts of the world, cities around the world, had become the setting for the pop-up construction of about 1,000 bed hospital facilities to deal with affected patients in different parts of the city as the hospitals became overwhelmed with new cases. And in this way, the various states had managed to somewhat make up for the initial response deficiencies with extraordinary measures to contain domestic transmission and concentrating medical resources where they were most needed. So while the governance of disease control and prevention has often taken place at a municipal scale, the increasing porosity between urban, suburban, and peri-urban places requires a new approach to understand the relations between and roles of key actors and institutions and human non-human relationships in influencing the transmission of disease and the ability of institutions to provide effective treatment and containment strategies. And this is something that political ecology is particularly well suited to doing. The growth of megacities and mega regions also raises the question of who has the mandate to control outbreaks in peri-urban areas. And as I've noted above, disease response mechanisms and other forms of governance may not be as well established in peri-urban areas, and that can result in increased vulnerability to infectious disease outbreaks. It also highlights spatial inequalities in healthcare provision within urban areas, and is important to consider how these various power relations and government policies at various scales can reinforce the social inequalities that influence vulnerability to disease. So one interesting example in terms of governance is from Hong Kong's response to the COVID-19 epidemic, which has not actually experienced a dramatic growth in cases like some of its regional neighbors, including Singapore and South Korea, and of course mainland China. But unlike in Taiwan or in the case of South Korea's recovery, the success can't actually be attributed to early effective action on behalf of the local government, but is rather due to the grassroots governance networks that had been extremely well developed due to the recent history of protests over the past year in Hong Kong, and also that many citizens had very strong memories of the SARS epidemic, which had badly affected the territory and arguably motivated people to take decisive action on their own. It also highlighted some existing tensions and discontent with the current government in Hong Kong. And so these protest groups really took it upon themselves to set up a website to track cases of COVID-19 within the territory, monitor hotspots, and warn people of places selling fake personal protective equipment, for example, report hospital wait times, and to provide other relevant information. And Singapore also had a similar website that used publicly available data to allow citizens to really understand recent clusters and the dynamics of the outbreak amongst the population. So Hong Kongers also spontaneously adopted a near universal mask wearing policy on their own, even though the wearing of masks in public had been banned due to the protests. And a large network of volunteers also distributed these masks amongst poor and elderly, people who are more vulnerable to the disease, and installed hand sanitizer dispensers in the crowded tenement buildings around Hong Kong. And when the government at first refused to close the border with mainland China, about 7,000 medical workers went on strike to demand closure of the border with mainland China and better personal protective equipment for hospital workers. Okay, so to wrap up then, it appears more important for the health of communities and individuals where in the world, and indeed where in the urban region they're located, and how these particular areas are changing in relation to their natural and social environments. And in particular, we've noted the massive increase of the global urban population over the past few decades, which has been primarily concentrated in ex-urban areas, which has posed new challenges to the control of infectious disease. So this includes processes such as population growth and movement between urban, ex-urban, and rural areas, as well as infrastructure provision, such as water and sanitation and land use change. And the urban political ecology framework that we've used is not only useful for examining the explosion of urban societies beyond their boundaries, but also the uneven and the socially unjust power relations, which can amplify health inequalities in particular places. So this is attention to socio-ecological exchanges along the urban periphery allows for understanding how outbreaks of zoonoses and other emerging infectious diseases can be triggered by the expansion of urban settlements in previously forested or agricultural areas. And such transformations are producing new ecological niches for the spread of disease, meaning that ex-urban areas are likely to remain a hotspot for emerging infectious diseases into the foreseeable future. So this, I think, urges upon urban researchers to seek new and better explanations for the relationships of extended urbanization and the spatialities of infectious disease, and to develop research along interdisciplinary lines to better understand these different political, economic, and cultural and spatial factors that affect infectious disease spread, as we're now actually starting to see, whereas previously research on infectious disease had primarily been done within health and medical research. So with that, I will leave it there and look forward to any questions that you might have. So thank you all for tuning in and being a good audience. Thanks.
Thank you very much, Creighton. Thanks very much for this very interesting overview on the subject of emerging infectious diseases and cities. I like your conclusion that we need interdisciplinary research to better understand this phenomenon better. That makes total sense to me, rather than siloing it just among the medical experts. Mm-hmm. So that's a very interesting conclusion, I think. I'd like to once again invite the audience to ask any questions or make any comments. And the way we'll do this, I'll explain it again for those who came later after the introduction. Please write your comment or your question in the chat, and in the order received, I will then read it out loud for Creighton to answer or to respond to.